بسم الله. I think we are live. السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Welcome to our second webinar organized by Saudi Anesthesia Society during this pandemic COVID-19. Today we are honored and privileged actually to present our second webinar with international and national speaker from the world. The webinar today will be the new normal of the perioperative medicine during the pandemic 2019 era. Our speaker today is coming from US, from Johns Hopkins, from King Saud University, and from King Abdulaziz Medical City. Man. The webinar will be presented by my colleague Ma'an Qattan as moderator. Ma'an is our colleague, is a scientific member of the Saudi Anesthesia Society. He's a chairman Department of Anesthesia, King Abdulaziz Medical City in Jeddah.
السلام عليكم. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Welcome everyone on board. Mashallah, tabarakallah. We started with already more than 1,000 participants or attendant. Thank you, Fahad. So we'll start first of all with our first speaker, Prof. Ahmed Zbeidi, who's a colorectal surgeon who has been involved heavily with nationwide in terms of surgery during this COVID pandemic, and he's going to talk in the next 20 minutes about the effect of COVID on the surgical care. Please, Prof. Ahmed.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد عليه أفضل الصلاة وأتم التسليم. First of all, I would like to thank the Saudi Anesthesia Society for this generous invitation, for asking me to talk about the impact of the COVID-19 pandemic on surgical services care. I would like to thank especially Professor Ahmed Turkestani for his invitation, the organization committee and the moderators. And I also would like to thank the people who are attending. And I think this is an electronic right more than just only a meeting, because this is the largest number I ever seen in all of the webinars that I have participated at or contributed to in the last 1 month and a half. I will start now my talk. First of all, I have no disclosures. So in the normal circumstances, what happens basically when we do booking for OR cases, usually the OR managers, when they do case prioritization, they take in consideration the medical necessity and the time sensitivity of the case, trying to integrate the hospitalized patients, emergency room, trauma patients, without forgetting the already previously scheduled cases and taking in consideration the OR resources. And when we talk about the resources, we're talking about the healthcare workers, the proper personnel for the proper procedure, the proper equipment, the proper protective gears that the surgical teams they have to use during the procedure, whether they are the surgeons or the anesthesia or the nurses or even the housekeepers. And this is what happened in the usual day-to-day organization of OR list in any hospitals in the world. And that was the common norm until the pandemic happens. So the first case, as we know, happened in Wuhan in December 2019. And then in March, the WHO declared that the COVID-19 is a worldwide pandemic. And the Saudi government, as any other government, they start taking their special procedures, trying to minimize the effect of this pandemic on the whole system within the country. And the medical healthcare system is one of these systems has been affected by the pandemic. So we started with gradual curfew until complete lockdown that happened in March. So this curtailing procedures is to allow the hospital to offload the inpatient census, and they divert and redeploy the resources, either the current resources or the predicted future resources to be scattered. And those are the personal protective equipments, the COVID-19 testing materials, the healthcare worker personnel. Those are very essential and important. The availability of hospital beds in general to be able to accommodate the patient who protect the infection, and the ICU beds in especially, and also the ventilators. And the people, they learned it from what happened in SARS in 2012, as well as what happened in Wuhan in China. And they found that those patients, when they protracted the infection, they become really sick. And they have about up to 20% mortality rate, as this paper showed from Wuhan that happened, and I mean that published in March this year. The researcher worldwide, they start to look at the effect of this COVID on the day-to-day work, and the global health in general, on the hospital capacities. And one of them is the COVID Surge Collaborative Group that is based in Birmingham in England, where they looked at the beginning of the pandemic, that was mid-February. They looked at 250 cases of COVID confirmed cases, and who underwent surgery, whether they are elective procedures or emergency procedures. And they found that the patient who protected COVID pulmonary complications, they have a higher mortality rate than the patient who did not develop pulmonary complications. So COVID by itself, adding to the morbidity and mortality of these patients on top of the surgical morbidity and mortality. And last month, they just published recently, about 2 weeks ago, 1,100 cases of confirmed COVID patients who underwent surgical procedure. And they tried to look at, is the mortality higher in the patient who comes to the hospital who already have COVID, or is it higher on the patient who developed COVID infection after undergoing surgical treatment? And basically, they found that this patient who developed pulmonary complication, who developed COVID post-operatively, they have a higher mortality rate than the patient who developed or who came already known with the COVID infection. And basically, the mortality was up to 4-fold the mortality of the patient who came out with pre-COVID. So the post-operatively COVID is more mortal than the patient who comes early with the COVID. And both of them, they are highly mortal to these patients. And from their study, they found that patients who are more than 70 years old, a male patient coming with comorbidity, emergency surgery, they have a higher mortality rate. And they recommend that we should have a higher threshold for surgery, and we try to postpone surgery as much as we can. And this, from these papers, hospital, they start discussing the morbidity and mortality of COVID if the patient protracted infection during the peri-operative period. And this one is the example, the National Health Card Hospital in Jeddah. They included the risk of infection with COVID-19 and the mortality rate associated with it in the consent form. And the patient will not go for surgery until they sign this consent form. So the patient right now, they are very well informed in some of the hospital about the possibility of having COVID and the high mortality and morbidity associated with this COVID infection. So what happened after March 11? so many national and international health authorities, organizations, and societies, they came up with guidelines to how to deal with this pandemic status. And the example nationally is wiqaya. Internationally, since I am a surgeon, in the American College of Surgeons, they came up with a triage guidelines for surgical care. And they basically divided the pandemic into 3 phases. Phase 1, where you have few patients. The hospital resources is not yet exhausted. The institution still has ICU ventilators and capacity. And they looked at what the cases that they should be done during this phase. And as the phase goes on, they have new definition for the surgeries that have to be done during each phase of these 3 different phases. Another society, this is the American Society of Breast Surgeons, and they succeeded to include with them the American College of Radiology and the National Comprehensive Care Network in CCN, and they issued a new joint recommendation, and they divided the situation into 3 different, the priority of the patient into priority A, B, and C, whereas A, it's a life-threatening condition and the surgery has to be done immediately. B, where the patient condition do not require immediate treatment, but should start treatment before the pandemic is over. And priority C, have conditions that can wait safely until the pandemic is over. And by this recommendation, it was a generalized recommendation. It is fit for not only breast endocrine surgery, but for the rest of the surgical cases and surgical treatment. The problem with this recommendation is basically what happened for the patients who are really having pain, but their condition is not life-threatening, but it can just cause more agony and atrocity to these patients, like patients who are having a hip joint or joint pain. It's just not only the restriction of the mobility, but also on top of that is the pain, which is a real issue for this patient. The British people, they tried to come with something called the Salford score, and they looked at the patient in 2 different, from the 2 different views. They looked at the case as a priority. So priority 1 or P1 and P2 are, they do not, they cannot be postponed and they have to be done immediately. P3 and P4, those are the conditions where patient can be treated within 4 to 12 weeks, and where the surgeon and the patient, they can have discussion around the condition about the postponing the surgery and trying to apply other non-surgical treatment until either they sort out the waiting list or until the pandemic is over. And they looked at the patient from as I said, from the disease condition and also from the patient vulnerability. So they looked at the patient age, the comorbidities, and they divided them into vulnerability 1, 2, and 3, where vulnerability 1 is patient is not vulnerable and surgery can be done because they are at low risk. They will not cause a lot of demand in the healthcare system. And the vulnerability 3, whereas the patient is extremely vulnerable, he's old, a lot of comorbidities, and in this situation they have to postpone the case until later on. And then they looked at the same time into the environment inside the hospital, whether it's the hospital is heavily loaded with COVID patients or the environment is free of the COVID case, and trying to put it in the sorting or in the scheduling of this patient. And they have certain conditions where the patient has to quarantine himself for 14 days. The patient has to be COVID negative, and a CT, they requested a CT scan 24 hours prior to the procedure. And all of these things, all of these precautions cause a lot of demand on the healthcare system and compromise the safety of the system itself. Hospital, they tried, like the Nebraska medicine in the United States, they tried to come with a contingency plan where they looked, is it symptomatic or asymptomatic? Is the patient COVID positive or COVID negative? And they come up with this diagram that you can see, which is basically is not easy to follow most of the time, and it needs a lot of guarding and policing, and it's not easy executed from physician point of view, patient point of view, or even the healthcare system point of view. This paper, or this is an editorial at the British Medical Journal from Department of Specialty Medicine in Rochester University, and they tried to come up with a definition for the cases. And they said that the cases either they are emergent or urgent, and then we have two types of elective: an urgent elective that it has to be done within 2 weeks, or an essential elective which can be done within the 3 months. And then there is a discretionary or a non-elective, non-essential list that can be done later on after 3 months, like the cosmetic and bariatric procedure and the joint replacement where the patient doesn't have a lot of pain. And then they try to figure out a scheme for whom should go for surgery and who should not go for surgery, taking into consideration the availability of the blood in the blood bank, the availability of the ICU beds. Is there any need for a special skilled nurse facility or a rehab? What is the ASA score of the patient? And they came up with this diagram recommending which patient can be done and which case should be delayed. And it is still also cumbersome, and there is no hard rules that the people that can abide by. It put a lot of burden on the physician. It creates some conflict of interest. It's morally not right, legally also not right. So what's the effect of this COVID on the elective surgery after all of these new rules and regulation and guidelines by different institutions and different governmental health sectors? It's been estimated, this is from the COVID Surge Collaborative Group, it's been estimated that 28 million cases has been postponed or canceled within the last 3 months. And in Saudi Arabia alone, it is about 113,000 cases has been postponed and cancelled, and 9,000 of them are cancer cases. And this will take about 1 year from the healthcare system in Saudi Arabia to catch up with the backlog with a 20% increase in the capacity. So this is a huge and a magnificent load on the healthcare system. Basically, in this paper, which just published about a week ago, they looked at the cancer cases, and they found that about 35 to 40% of them has been canceled, whether it's a general surgery, gynecology, head and neck, plastic, hepatobiliary, urology cases, or orthopedic cases. And most of the benign cases, up to 80%, has been canceled because under the effect of this COVID pandemic. And when they looked at when they divided the countries that contributed in this study into high income, middle income, low income countries, they found that the cancer cases in the high income countries, 30% of them has been cancelled. In the low income countries, more than 70% of them has been cancelled. And when they looked at the benign cases, almost 80% of them has been cancelled in all different income countries. So unfortunately, if cancer surgery is postponed indefinitely, this will cause potential risk that the disease will become more advanced. And this dramatic and drastic immeasurable impact on the healthcare of our communities is more and beyond the morbidity and mortality inflicted by the COVID pandemic itself. So what we have done trying to protect our healthcare system actually caused a lot of and higher demand on our healthcare system. And always we try to think, and I mean, the people who are in the decision-making positions, they always try to balance between the disease progression, the worst patient outcomes, and the risk on the healthcare worker the exposure to the virus, the resources of the system, the sustainability of the system, and it's like a vicious cycle. Wherever you try to press it for one side, it doesn't get you into the in a good balance. So what's the meaning of the time-sensitive surgery? The cases in general, they are divided into non-time sensitive, where scheduling surgery for patients in whom postponement will not have a negative impact on the patient health. While the time-sensitive surgery is the scheduled surgery for patient in whom a delay could have potential negative effect on the patient health. Then we have the urgent and the emergent cases where they have to be done immediately or within a short period of time, or otherwise it will cause significant morbidity and mortality on the patient health. Well, concentrated on the time sensitivity, because here, this is the majority of the patient will lie within this time, the definition of the time sensitive surgery. And with the time sensitive surgery, we have either we can postpone this patient or give him another non-surgical treatment if it is available, or wait until the pandemic is a little bit less or over, or we schedule them according to a priority. So there are a few questions here. First of all is, how effective are non-surgical options? Second question is, for how long would we wait? Would a wait for 2 weeks or 6 weeks make the operation riskier or more difficult to perform? Would it increase the chance a patient might have complications? Or what is the effect of this delay on the length of the hospital stay? All of these questions are not easy to answer. And the case where a delay adds significant to the burden of the disease experienced by the patient, this is one of the definitions of the time-sensitive surgical cases, or is as the time passes along, knowing how to manage this patient will become more challenging. And the examples are acute exacerbation of a simple biliary colic, or a chronic deterioration of bariatric cases where they have in the future would lead to more morbidity on the patient, or persistent disability and pain, like the severe osteoarthritic patients that are requiring joint replacement, or cancer cases where you can treat them with radiation and chemotherapy or surgery. So which one is what, and for how long should you delay, and how much of the should we go out of the norm in terms of the usual treatment of such cases. So many different institutions, they try to come with an elective or with a prioritization scheme. And one of them is this coming from one of the universities in the United States, where they try to put an elective surgery acuity scale as a guidance to the surgeon when they book the cases, and as a guidance for the OR management when they receive these cases, which one should go first. And they divided them into tier 1 and a tier 2 and a tier 3. And then they divided them into an A and B, where tier 1 is low acuity and the surgery can be postponed, and a tier 3 is a higher acuity and surgery should not be postponed. The problem with this acuity scale is lack of sustainability. It's not transparent, lack of dynamic, and there's a huge emotional and ethical workload on the surgical team and on the OR management personnel. So people, they continue thinking, and this until I found this paper that is coming from University of Chicago, where they try to define the case as medically necessary, time-sensitive prioritization, and they formed a team of 6 team members, and they are represented from general surgery, vascular surgery, surgical oncology, transplantation, cardiac surgery, otolaryngology, and they include with them the surgical ethics. And they went and reviewed the effect of the COVID on the surgical patients in Asia and Europe. And they looked at also the hospital resources, the effect of the COVID on the healthcare providers, the surgical procedure itself, and they came up with 21 factors that are important and related to the outcome, the risk of viral transmission, and the use of the hospital resources. And they divide, or they grouped this 21 factors in 3 different groups. The first group was basically the procedure factors, where they looked at the OR time, the estimated length of hospital stay, the possibility of a need of an ICU bed post-operatively, anticipated blood loss, surgical team size, the possibility of re-intubation after extubation, where is the surgical wound and the site of the surgical wound. The second group was the disease factor, whether a non-operative treatment option is effective or not, and what's the effect of the impact of 2 weeks delay on the disease outcome and the surgical difficulties. What's the impact of 6 weeks delay on the disease outcome and the surgical difficulties? And then the last group was the patient factor. What's the age of the patient? Does the patient have comorbidities like lung disease, obstructive sleep apnea, cardiovascular disease, diabetes? Is he immune compromised? Does he have flu-like symptoms? Has the patient been exposed to COVID positive patient in the past 14 days prior to surgery? And then they give these factors a scale of 1 to 5. They gather them in one sheet where the surgical team, they have to fill it up, and then it gets computed. And the total score, it goes all the way from 21 all to 105. So the higher the score, it means that this is a worse outcome, a greater risk on the patient, higher utilization and use of the hospital resources, a higher chance of viral transmission and exposure to the healthcare system. And if the score is high, they would recommend that to postpone this procedure, and the procedure is not justified. So this patient goes low at the prioritization list. If the score is close to the 25, then it is okay to proceed with the procedure. And to be honest with you, from the review of the literature and what we have seen in the recently, either in our hospitals or internationally, I do believe that this is one of the best prioritization scores that I have came through. It is ethically and morally better for the surgical team and for the OR management, where they have some sort of a guideline that they can put the patient in a good prioritization. And as any other scoring system or prioritization system, it has its own limitation. Just only 21 factors has been identified. There could be other important factors that will be identified in the future. Unfortunately, this score doesn't anticipate the availability of resources like management of complications, readmissions, deviation from the routine post-operative course. But to my knowledge, this is one of the best available scores that hospital can use in the future. So how do we prioritize cases, and how can we do scheduling? This has to be done by a committee that the hospital has to put as a prioritization policy committee, where it should include a representative from surgery, a representative from anesthesia, and a nursing leadership. Those people, they know what is available in their hospital, what are the resources available, and they know the case mix and the capability of the hospital. And the aim of this is to develop a prioritization strategy and appropriate to the immediate patient need. And then this committee, they should look at the list of the previously canceled cases, the objective priority score, like the medically necessary time-sensitive instruments that I showed earlier. They should look at the specialty prioritization. That's a cancer case, organ transplant, cardiac or trauma. They should give an OR, allotted the OR time. The administration, they should be flexible with the overtime to the healthcare worker. They should identify the essential health care professionals and medical devices represented per procedure. The outpatient and ambulatory should be started first. Ensure adequate availability of inpatient hospital beds, and ensure availability of enough resources. And they should not forget continuous training for the newcomers in the hospital. In summary, ladies and gentlemen, deliberate decision-making around surgical cases should be done in all hospitals. Unfortunately, the decision is not easy, and it will be more challenging, not only now, but also after the pandemic is over. The course of the pandemic and the impact on the surgical system is a variable between hospitals and between countries. The institution should establish their prioritization policy committee. Each facility should have an objective priority score according to their own resources, expertise, and healthcare demand. And thank you so much for listening to me.
Thank you, Prof. Very well taken, excellent presentation regarding surgical care and the compromise with COVID-19. Now we'll take you through our timeline, and we'll go next to our next speaker, Dr. Abdul Alim Atasi. But before I introduce him quickly and he can start, we'll let you know that actually the Q&A questions we will be actually done at the end of the 3 presentation, which is about 20 to 25 minutes each. So we have 2 more presentations to go. Dr. Abdalim Atasi is a pediatric anesthesiologist and intensivist as well in cardiac anesthesia. He is a colleague of mine who's working in Riyadh and Cash Hospital in Ministry of National Guard Health Affairs in Central Region. He's the Deputy Chairman of Anesthesia Department in Cash Hospital. He's the OR Director, and he's also the Corporate Deputy Quality and Patient Safety for OR Management. And he will take it on now to the journey where we go with this: when to resume, when we de-escalate, when we re-escalate again, OR management in general, testing, PPE, OR scheduling, how we can fit in this issue. And he might even take us into the using other scoring systems that might be developed locally. The floor is yours, Dr. Abdali.
Thank you very much, Dr. Mann. I really appreciate this kind of invitation and appreciate, actually, thanks very much to Prof. Ahmed Turkestani, the chairman of the Society of Anesthesia in Saudi Arabia. I have to say, Prof. Ahmed Zubaydi raised the bar very high, mashallah, tabarakallah. So let me try to keep up with his pace. Having said that, I'm gonna just take you through the journey of what happened since March all over to now. And before doing this, I just need to share my slides so we are all on the same page. Here you go. Now, if you watch in my first slide, this is a picture on the right side, and it's a very representative of the operating room, I guess. And maybe if you would like just to reflect on this picture, you see that the people may be protected for regular procedures, non-arousal generating procedures. But what about the social distancing? What about keeping people apart? What about not transmitting an infection? That's what makes the operating room a very, very, very unique place. Imagine one single exposure, how many personnel can it cost you? We actually had this event at the very beginning of the pandemic, and one single exposure cost us 31 personnel, 31 person that we need actually to isolate for 14 days. Now, how many 31 person you have in the operating room? That makes it very, very, very unique and very challenging. And as Prof. Ahmed Zubaydi said, we really don't know where we at or where we're heading. So, which makes it very, very challenging based on the plethora of the information that we have coming. Now, again, I would like you just to close your eyes and let's think about March. Let's think about the very first case of COVID coming to your operating room, and what was the feelings among the staff. if you allow me, I institute, at least I've seen not knowing what to do or those cases, and how far are they protected, and what will be the sequelae of the infection itself. So that's why I'm going to start with the foundation. In order to de-escalate, you have to make sure that you're paying for COVID positive patients, which only going to get more, is very stable and very robust in a way. So a preparedness for the COVID-19. And this is going to take you back to the steps that probably most of us did it in our operating room. The PPE availability. We all remember that we had a problem in how much N95 we have, how much PAPRs we have. Some of us still were looking for PAPRs, and actually it's not even available in the regular market. The surgical masks, the sensitizers, the alcohol swabs, the staff training, the doffing and donning, and how do we do it. I remember in at least the level of corporate and National Guard, we all conducted simulation drills in order just to make sure that the staff are really familiar with this process and the pathway across the operating room. Dedicated operating room, and how you have to minimize all the medical equipments inside that room so the contamination will be less, and what's the process of cleaning, the using fumigation and other kind of protocols in order to make sure that everything is crystal clear. The ventilation system. We all know that the ventilation system is extremely important in the operating room in order to prevent any infection. And we have to have 20 cycles per hour. Having said that, many would try to move the operating room from the positive ventilation system into the negative ventilation system, and that's not that easy. It's expensive, it's troublesome, and the other option is just to move the operating room from positive ventilation into neutral ventilation and bring the HEPA filters and the availability of the HEPA filters in the market. Then the tracing registry and the role of infection prevention and control, because every exposure, especially if it's unprotected, then you need to go back and trace all the members or providers and make sure that they are safe and sound, and also they are not exposing other patients to infection. Then the written protocol and the patient journey, and how's the patient's coming from the emergency, and how's the patient is moving to the ICU afterward, and which ICU. Those all kind of questions that we all needed actually a few weeks in order to absorb, to identify the weakness in the system, and to address, and in order to make sure that we are safe and sound for our patients and for our providers. Now, when you do all this, and you start to get the positive COVID patients, and everybody is protected and safe, this is where you gain the trust in the system, at least from the provider's perspective. And then you are actually ready to move forward. So, and then the question comes, when do we resume elective procedures? And as Prof. Ahmed, it's extremely hard question to answer. If you're gonna go by what's written in the American College of Surgeons, for example, they tell you you need to wait between 14 to 21 days after the peak of the infection. But we all know that this pandemic has been lingering for a long time, especially in our country. And we actually need to look into the COVID-19 impact at the national level. And there is a royal decree has been coming just a few days ago, just making sure that all country in the same page in terms of escalation and de-escalation at the national level, then at the regional level. And last step is the institute or the institution level. For example, for different hospitals and Ministry of Health, they all need to be on the same page and in the same occupancy and the same level of preparedness in order to be able to de-escalate slowly. Now, after that, so when if we're going to go again, let me just reiterate, it's 14 to 21 days after the peak is going down, but this has to be organized and synchronized with the national and the regional command center. Then we need to look into the different matters in our institute itself, and that's the staff and the patient safety, the beds capacity, the case mix, with Prof. Ahmed actually alluded to and very extensively, and the supporting services. And I would like to twist the talk a little bit about the staff and patient safety. And I would like just to make sure that we're all, if there's one single message actually to come out of my talk is this slide. And it's the balancing between the acute respiratory infection tool, which basically it's a fancy term for the symptoms of the patient, versus the COVID-19 swab testing. Okay, and as you can see here in the seesaw, it goes toward the symptomatology, and probably if there's anything allude to that is the announcement that came out from WHO yesterday, which clearly states if patients have no symptoms, the likelihood of transmitting infection is extremely low. So in another term, we always need to look into the symptoms of the patient first. COVID-19 swab testing is good, but not as good as the making sure that patient has been screened extensively from symptoms perspective. Now, let's talk about the test. This is a research paper, came on March 11th in the JAMA. In the JAMA journal, and it's about the detection of SARS-CoV in different type of clinical specimen. And I think this paper made a huge difference. And if you allow me, Prof. Ahmed, it made the surgeons very, very observant of this pandemic, actually. So what they did, they took around 1,000 sample, if not mistaken, from 205 patients, and they took different samples, and they looked at what's the chance of recovering the virus from them. And as you can see here, from sputum, the sensitivity was 72%, while nasal swab was 63%. But you look at the number of samples, is extremely minimal. We generalize in the sputum sample. When it comes to the pharyngeal swab, the sensitivity was around 32%. The recovering virus from fecal material was around 29%. And probably this is where the American College of Surgeons came out clearly stating that any surgery includes the lungs, or basically thoracotomies, or any procedure involving the gastrointestinal tract is actually considered a arousal generating procedure. And then our colleagues and surgeons became really, really concerned as our colleagues in anesthesiology dealing with the airway, and they can definitely, they will be during the intubation managing arousal generating procedure. Now, let's look about the test, how we can interpret this test. And this is another paper that was published by the BMJ, if I'm not mistaken, and it shows the ability of the test and identify COVID positive patients, truly. And I will take you to the next slide, that makes it easier. It all depends on the pre-test probability, and that's in a term for symptomatology, the symptoms of the patient. How likely is this patient having COVID compared to the regular population? And based on what we know now, the test sensitivity of 70%, the test specificity of 95%, out of 80 patients from the 100 that are being tested that we think they have COVID, based on the current testing, only 56 are going to show true positive. One going to show false positive, which basically he doesn't have the disease, but the test identified him as positive. And 24 false negative. Basically, they are people who carrying the, but they tested negative. And this is the whole trick. So the test is never enough. And what's really important is the symptoms of the patient. And we always need not to be misled by the test. We have to concentrate on the symptoms of the patient at all time. While only 19 comes up true negative, and that's what's expected because we said the pretest probability is around 80%. So this is the real message here that yes, we need to screen the patient from symptoms. We need to test them just to confirm that. But we cannot rely on the test only. And test by itself, if the symptoms is positive, is never good enough. And we have to take all the precautions. Now, this is a new perspective article has been published in the New England Journal, it's around like 3 or 4 days ago. And it states clearly a big concern has been test availability, but test accuracy may prove a large long-term problem. So we need to be careful with the interpretation of the test. And we always need to take it back to the context of the patient circumstances and disease process. Moving forward, this is another paper that Prof. Ahmed has just referred to, and it's the outcome of patients who are infected with the COVID-19. And as he stated, if you look at the mark here, it's a warning, and it's a warning from two ends. From my perspective, as probably as an OR and also as an anesthesiologist, if you allow me, that the 1,000 plus or the 1,200 patients that this study looked at, it showed a very worse outcome, actually, which was mortality of 23%, if I'm not mistaken. But if you look at the population of this study, 50% of them are above the age of 70, 50% or more have high ASA score, and 50%, I think, going to the emergency, underwent an emergency procedures compared to elective procedures. And this mix by itself is by definition, again, it put patients more at risk of higher mortality. But we didn't see this much of mortality before the era of COVID, and that's where the trouble comes. But if you allow me to look at it in a different way, and that goes to the odd ratio that actually Prof. Ahmed also he presented in his paper, that there is a big chance for those who get infection post-op that they're gonna do worse, and that's why it should be translated into a pure consenting and a clear explanation to the surgeon, because he's entitled for that. He needs to know if he, God forbid, he got exposed to COVID-19 and he retracted this infection from whether health workers or from being in a hospital, their outcome really, really worse compared to the normal population. On the opposite, actually, in the contrary, those who came with the COVID-19 pre-surgery, they actually did better. And that makes you think a little bit about this study. And we also need to remember that it's conducted in around 100 plus hospitals from 24 countries, while their healthcare system is really strained. And that's extremely important. We are going through this phase now in Riyadh, and we know that our ICUs are not in the same level because the expertise are different. We are forced to bring healthcare providers that not necessarily doing critical care into that field. So the personnel has been moved from a place to another. We're upscaling their skills, but not necessarily at their best performance. And definitely, the regular morbidity or mortality and regular complications are probably going to catch up higher because we are really strained as a whole system caring for this gush of patients coming through the door with the COVID infection or with this pandemic. So the take-home message from this slide, if you allow me, that the patients should be aware, and we need all to be ready and prepared to tell them that if he gets the infection after the procedure, his risk is sky high for major complications, including mortality and major respiratory sequelae. Now, let's talk about the bed's capacity. So if you look at my slide, I put the day surgery in green and a critical care bed in red. And this is the whole message. When we are ready to de-escalate and the surge of number of cases is going down, and we have a more capacity to take care of those patients, we really need to account for beds availability for COVID population. And that's why the first thing to start with probably is the day surgery, where the capacity of the hospital will not be impacted. After that, we can consider the same day admission. Now, I know in our country, the same day admission model is not necessarily has been implemented in many hospitals. And it's actually a venue for us to change the thinking. And that's one of the new norms that we need to think of. We need to minimize the exposure of the patient to hospital and healthcare workers and bring it to the bare minimum, as long as we provide a very safe and sound and robust care. And that's why we need to move, if you allow me, to that direction. Okay, so whatever needed inpatient and bed in the regular floor, probably we need to minimize his stay as a length of stay post-op, and we need to bring him just at the day of surgery, so going to that direction. and prepare him as an outpatient. Those surgeries that we used to do them as an inpatient, we need to move them further to the left and do them as a day surgery. And we need to be very considerate in terms of how and when we use critical care beds and what kind of critical care beds. And is it COVID clean unit versus COVID units? And we look into this capacity in order to minimize the exposure or the risk of exposure of the patient to God forbid, to COVID positive infection. Now, the case mix, I think that has been studied extensively by Prof. Ahmed, but let me explain what at least happening in our center. So cancer care. It's extremely hard to stop cancer care. And actually, if you think from patient experience perspective, I'm not sure how many weeks you're going to wait. And there are many articles came out that you can wait maybe 4 to 6 weeks, the maximum. But after that, it's a big question mark about the outcome of the patient, of the exposure of the patient. So looking for alternative approach, if available, radiation or chemotherapy, that's an option. But probably you're going to end up doing those cases in a timely fashion, regardless of the constraint, as long as you have a capacity for sure. Time-sensitive cases, coming from the world of pediatric anesthesia, there are very time-sensitive procedures from the congenitality perspective, the cleft lip, the cleft palate, the craniosynostosis, some certain cases of secondary scoli. So we need to look into that. It's hard in general to delay, but you know, it gives you a little bit more slack time compared to the cancer care. Obstetric care, and now I'm speaking from operating room management perspective. Those C-sections are coming no matter what. You cannot stop. Okay, but what you need to do to make sure that your process is very robust and not to give them infection. And honestly speaking, we're starting to see a lot of C-sections with COVID positivity. Luckily, most of them, they don't get really sick, and that's in the contrary to H1N1 in this population. Staged procedure, hard to delay. Organ transplant. Now, this is a big question. It's risk versus benefit. The last thing ever you want to do, based on what we know from evidence, that giving somebody a new organ and he's immunocompromised and then he gets COVID-19, the outcome really going to be a major negativity in general, or major complication, or maybe in fact reaching a mortality level. On the other side, those who have been waiting for a long period for cadaveric organ and they had the chance, what would you do with them? And how can you make sure that they're going to get the organ and they're going to be safe and dealt with in a safety fashion, especially their length of stay is extensive. Now, elective procedure, this is where the scoring system can work very well. Prof. Ahmed mentioned his the scoring system that comes from the Chicago group. Ourselves, actually, since we're a pediatric hospital, we looked for a pediatric scoring system. I'm not sure we found one. And actually, we created one very simple and from 6 elements, looking into the ASA, looking into the bed's capacity perspective, the time sensitivity, and length of procedure itself, and the requirement for blood transfusion. And that worked very well for us in the cache. Now, lastly, looking into the supporting system. Now, we all know that the COVID-19, as if we put a hold in the ward manufacturability. So the supply chain in general got paused somewhere, somehow. For many reasons. It's for trading impact, for transportation impact, for manufacturing impact. So there are many medications that we never thought that it's not available, not going to be available. They're not available now in the market. And some of them anesthesia related, some of them chemotherapy related. So we really make sure from medication perspective that we are okay. And when you're going to start to think about de-escalation, you have to put this in a factor within the calculations of what you need to do. The consumables, that's exactly the same. So the implants, the regular supplies, we need to make sure that's available. Our colleagues and other services in terms of the manpower and ability to diagnose with an interventional radiology, the ability to report, and with the impact of COVID pandemic onto their manpower and reporting ability in general. Our colleagues in the pathology, in the laboratory, the medical staff, the nursing, using, especially now, they are being deployed in different units and upscaling their set of skills. So you're going to find that you're losing nursing from recovery room, nursing from day surgery, nursing from the regular floors. That's the ratios is going down. This is all that you need to think of and organize before moving to the next step. Now, assuming you addressed all this and now you're ready to move forward, the biggest and the real challenge, and we're actually facing it now in the pediatric population and their parents, the patient trust. And how can you convey the message that they will be safe and sound getting this procedure done in a timely fashion? And if you look at the literature now, it's going all over the place in terms of what are the different tools that we can use. And one of them for sure is the transparency. So every hospital has to publish what kind of cases they have, how many beds available they got, what's are the, they can provide dedicating material for the patients in general, and actually even videoing the journey and what the social distancing measures and what's the facility change management that they have implemented in order to keep the patient safe and not being exposed to risk of COVID-19. And also keeping an open dialogue.
5 minutes, Abdul Alim, please.
Sure, almost. Maintaining an open dialogue between the healthcare providers and the patients and their families, especially for pediatrics, in order just to convince within, well-addressed measures and implementations that they can come to the hospital and get the surgery done in a timely fashion and also in a safe way. Now, when you look at the resources, there is, I would repeat this word again, there is lots of information, lots of data, but many of those data not necessarily evidence-based. Many of them is just as a more precautionary, and you can see that many facts today as being questioned maybe 6 or 8 weeks down the road, and we're rethinking about them again because we really we're in a very ambiguous situation, like 3 or 4 months down the road previously. But now I think there are more information that makes us more comfortable to deal with the case, and we're starting to think in evidence-based medicine and applying real randomized studies to have very good evidence. So American College of Surgeons is a great resource that actually we used in the corporate of health institutes in the Ministry of National Guard. You have the Royal College from UK. You have the obstetric and gynecology societies as well. There are lots of data available, but the question is which one you're going to implement, and we have to understand that what you're using today can be very well addressed tomorrow in a different way and looked at in different prospect. And with that, actually, I would conclude. Thank you very much.
Thank you, Abdul Alim. This is an excellent presentation. It's very rich and answering a lot of questions, during this pandemic from pre-op testing. And so now we are coming to our third speaker. It is my honor and pleasure to present Dr. Mohammed Rahman. Dr. Rahman is the chair of Department of Anesthesia at Johns Hopkins All Children's Hospital. He's a professor of anesthesia, critical care, and pediatric with Johns Hopkins University School of Medicine. Dr. Rahman is internationally recognized for his medical and clinical informatics, and he leads a peri-operative health informatics unit. He's an author of more than 50 original research publications and review articles and more than 70 scientific abstracts. His leadership role in national level and international level serves as the chair of Biomedical Informatics Technology Group of Society of Pediatric Anesthesia and the president of Society of Technology Anesthesia. Today, we are honored to having Dr. Rahman with us to talk about the new norm of the anesthesia practice. Dr. Rahman, mic for you.
Thank you, Dr. Fahd, Dr. Maan. This has been interesting times. If you look at life, when you have a disaster, you can look at it at 2 ways. When there's a fire, some people run that says a fire, run for your life. Other people say fire, maybe there's an opportunity. Being a data scientist, this is an amazing time for me to look at new data, new models, new innovation. Having said that, this is a very, very stressful time. I don't know if you all saw the story of Dr. Laura Breen. She was an ER physician in New York. She did 12-hour shifts, 12-hour shifts, 12-hour shifts, finally got COVID and committed suicide. We don't want a single healthcare death if we can avoid it. So I'm going to be talking on how to apply technology to improve patient care, what has been the current state of healthcare workers, and end up with where we are. We are like a couple of weeks ahead of you all. We have reopened, and what lessons have we learned? So I thought Dr. Fahd told me to talk about telemedicine because he knew that I had started telemedicine 10 years ago. Telemedicine, basically, when I wrote this article almost 10 years ago, there was two types of telemedicine, either static or dynamic. Static is when you send the reports and somebody gives you an answer, hey, you can do this or not. Dynamic is when you use real-time dynamic telemedicine. So here we are 10 years later. Today, telemedicine is the norm. About 12 years ago, I had started liver transplant in India. That was the first liver transplant case in India. Then I did not go there, and there was some anesthesia-related complications. So we managed patients in real time in India in 2008 from the US. The kids did well, it was a good learning experience, but it was day there and it was night. And look at one of my partners here, he's telling what I got myself into. So, but it was a good learning curve, and telemedicine consultation has been there, but now we are moving it to the next level. One of the important things I talk to anesthesiologists is you are not just an anesthesiologist. You are a peri-operative medicine doctor. What does it mean? You help everybody else in the peri-operative domain. So when COVID started, we being data specialists, we said, how can we help with telemedicine? So we started a whole telemedicine dashboard. What does that mean? If you look here, we used to see about 600 patients in this clinic. It is just not anesthesia clinic, they're multidisciplinary clinic, but this area. And then right then you see all going down, and here we are now, we haven't reached anything. But if you look at video, this is video, the color of video, we have gradually gone up, and now we're coming down, which means the reopening is we're seeing more patients in person and less video visits. Also, if you look at the total number of ER visits, we are just at 41%. This is in-person visits, we're at 41%. Phone visits, half of our phone visits are really video visits that failed. So we are still at about 19% and 36%. But the important thing to see is our net amount of cases coming over to the clinics is increasing. The in-person cases are increasing. The phone cases are going down, and the video cases are going down. I think that's what you need to see. You're going to see all cases go down, and then you'll gradually see your video conference going up. In the initial phase with the video conference, you're going to see phone calls go up because you're going to have a lot of failed video conferences. And then gradually your inpatient visits are going to come back. This is a very good way of getting your pre-operative patients that you have in the backlog ready so that when you ramp up, you don't have to waste time. The other thing is, here is a thing of satisfaction count for the user who's using telemedicine. If you look here, they were not satisfied because You're telling people who had never done telemedicine to do telemedicine. The phone lines, the video lines were not working well. The patient level connections was failing. But as we went through this example, in about 2 months, the satisfaction is way up. The red is almost down. So it is now set. This is innovation, which means now telemedicine is here to stay. Telemedicine is here for preoperative visits and can be a new norm. And this is what we have learned. Look how well we're doing. We were not doing well with telemedicine. Now we're doing so well. The other thing is, look at the amount of failed visits. If you look here, the amount of successful telemedicine visits have gone up and the amount of failed visits have gone down. And that's what we want to see. Initially, we did not have a good amount of companies. Now there is Zoom, there is Microsoft Teams, there is several other companies. The system to do telemedicine has matured and has significantly matured in the last 2 months. So that's a good thing. So in a nutshell, I think what we have had is an opportunity here to learn how to utilize telemedicine. We know which patients can do well with telemedicine. Like, for example, with pain patients, the initial intake we do is a multidisciplinary pain intake, which is an anesthesiologist, a rehab doctor, a psychologist, rehab physician, a rehab technician. But the follow-up now, if they need psychologists, they don't need to come to the hospital. It can be done by telemedicine. If you telemedicine. So it has set a new norm, which is a positive. We can now improve healthcare delivery with all the lessons we have learned. The second thing I'm going to talk about is how has it affected the healthcare worker? If you look at the story of Dr. Breen, it is sad because there were many healthcare workers like her who got exhausted but had no choice, and they were putting patients before their own health. If you follow the Harvard Business Review, if you follow Wall Street Journal, there were a lot of articles coming out very early in March telling anxiety is contagious, it is dangerous, it is take care of yourself. But we as healthcare workers, we take care of patients, we don't take care of ourselves. This is the first time I've been doing pediatric anesthesia critical care now for 20 years. This is the first time when we talked of patients being, practitioners being number one, their PPE being more important, and next is taking care of the patients. We put the practitioners and their families as equal or more important than the patients, which is a paradigm shift. So here are simple terms that are very important. Fear. Fear is something that when you see an unusual circumstances, you get scared, the circumstance goes down and fear goes away. Now, if you have an unusual circumstance, you don't know when it's going to end, you don't know when it's going to be, that's when fear starts changing into anxiety. Here is, we are in COVID. Am I going to get infected? When is it going to peak? When is the hospital going to open? We don't know. So there's a lot of anxiety. Fear is going into anxiety state. When anxiety gets very high, you go into panic state. So there's some of the healthcare workers who are in panic state. We need to make sure we find them and help them through. And there's this new term now called emotional infection. We know viral infection, we know bacterial infection, emotional infection. Just talking, and the news channel 24/7 is making us emotionally infected and increasing the amount of fear, anxiety, and panic. So when anxiety becomes unbearable, it can affect your work. it can make you do things that you normally would not do. So what do you need to ask? Simple questions. Ask these questions to you and your team. Are the signs of anxiety reaching unsustainable levels? This is very different. What is a norm in Saudi Arabia is very different in America, is very different in China. This is local level, and what may be considered anxiety in the US may be considered norm. So you need to look at your local area and see, are people getting more anxious? How can we talk about it? And let people express it. You don't need to give an opinion and say how to solve it. You just need to listen. Look at your boss, look at your colleagues. Your boss may be getting burnt out, but he doesn't know, because not only is he worried about making sure the ORs reopen, he's also worried about making sure the backlog is not too much, making sure the operating rooms can open on the weekend. So if your boss is looking tired or anxious, talk to him, and you can tell him in a nice way, maybe you need some time off. There is a high level of anxiety. Sometimes it's troubling, but the most important thing is workplace performance is going down. You see a worker who is one of your best workers now is doing mistakes that you don't see. One mistake is understandable, but you see 2, 3 mistakes. You may have to pull him out of work and get him help. Normally what we do is each hospital has got its own process. We have a 1-800 number where you can call, they will talk to you, they'll help you and walk you through it. And I'm sure each hospital has its own systems. This is the time where you have to give practitioners importance, because we cannot afford to lose even a single practitioner if they commit suicide, harm themselves, or harm their families. This was a very good article that came out telling that they're seeing a lot of burnout in leaders. The leaders put on a tough face. They want to be a role model. Hey, I'm handling this. I'm doing everything. But internally, they're falling apart. So if you see your leaders, you could be an OR director. If you see your CEO getting tired, you can talk to him and say, are you okay? You look tired. Are you okay? You look anxious. If you don't share and don't open up and talk, that's when bad things happen. And you need to make sure your practitioners are protected, feel comfortable, and listened to. I'm a pediatric anesthesiologist. Normally, we have both the parents come in and we take care of them very well. Now the children are coming alone. They're more anxious because they see something is not right. Even kids who are coming in for chronic conditions see anxiety in the hospital, see anxiety in the practitioners. So you can use new biofeedback therapy. Actually, the biofeedback therapy has even helped practitioners. So what we do is, when children are very anxious, we use new modalities. iPad everybody's using, but we use virtual reality. We had a child yesterday who came in, was crying and crying and crying. The moment we gave her the virtual reality set and she could see what she wanted, she was happy. She didn't need any medication. And we use that even for induction. So thinking out of the box, using technology to calm your patients, especially if they're pediatric patients, is helpful. Again, going back to say that when things are going bad, this is a good opportunity for innovation and thinking out of the box. So most of my research is around human digital twins, like creating a digital twin for every human being. So we take all the data. If you have a Fitbit, an Apple Watch, your EMR, we create your digital twin. And if your digital twin, and then we apply AI, if your digital twin is doing well, we nudge the digital twin to do better. And if the digital twin is getting sick, we want to bring it back to normal as quickly as possible. So here, if you have a simple idea, very simple idea, my baseline heart rate is 62. I sleep 7 hours a day. I do 12,000 steps. Now you're seeing, hey, I'm sleeping only 4 hours. My steps are down. My heart rate is up. That means something is not right. Take care of yourself. Here's an example. I know my heart rate, my steps, my sleeps well. In the last 10 days in the US, because of the riots, it's been pretty stressful. This is my normal sleep. I normally sleep about 5.5 hours to 6.5 hours. But in the last week, I was sleeping 4 hours and 5 minutes. I didn't need anybody to tell me, hey, something is going on. You're stressed. You're not sleeping well. Your baseline heart rate is up from 62 to 68. So I got to take care of myself. So what did I do? One, I stopped looking at TV. Two, the hospital uses an app called Calm. It helps mindfulness. I used that. Three, I started exercising. And within 3 days, my sleep was back to normal. My heart rate was back to normal. And I felt less anxious. Understanding your body, understanding your digital twin is very important so that you can take care of yourself. This is a time when you have to take care of yourself, your families, and your colleagues, and also the patients. It's a change in paradigm. So coming back to, in the Johns Hopkins health system, we have about 10,000 backlog cases. So what we do is we look at every day. Everybody gets a COVID test. Everybody's tested within 72 hours. If the test is more than 72 hours, we redo the test. We have published, I'm a part of an organization called the Pediatric Difficult Airway. Clyde Matawa and the group has published a consensus statement on how to manage the pediatric airway COVID patients that should be available free on the Pediatric Anesthesia Society, Pediatric Anesthesia Journal website. So this is how we track. Our next thing is this. Here is a running blog. You can run this for your hospital. If somebody is at the national level, they can run this at the national level. You're not only looking at cases, you're also looking at minutes, because there are three important things that are going to affect how quickly you can catch up. One is personnel, nurses, surgeons, anesthesiologists, and other folks. Two, PPE. If your PPE is low, you cannot do anything. Three is locations. So these are the three rate limiting steps. So you need to control the rate limiting steps. Next, you cannot catch up all the cases in 1 month. If you look at it, in our hospital, our only pediatric cases, we do about 60 pediatric cases a day. Now, if we have we have about 2,500 backlog cases. Even if we catch up 10 cases per day, it's going to take us about 2 months. So be realistic and try to be transparent so that everybody knows where we are. Some surgeons understand, surgeons are anxious, but do the right thing. Transparency, communication, good communication between surgery, nursing leadership, and anesthesia is very important to capture the backlog. So what has changed in my practice from a day-to-day basis? We are now 2 weeks back to full operation. Every child is getting COVID tested 72 hours before. Every child who comes in through the emergency room for an emergency case gets COVID tested. High-risk cases, airway and GI cases, we use N95, to intubate everyone, because even if the test is negative, it doesn't mean that it's negative. PUI, any person under investigation is treated like they have COVID. We have got COVID markers. We use the COVID disinfectant. Anyone with PUI, even if the test is negative, they're treated like COVID positive. And COVID positive, I'm sure every hospital has got guidelines. We follow the national guidelines, which is making sure the personnel involved stay localized. Everything is cordoned off. There's a special way the children come in, the special way they go out, and we follow the COVID positive children's methodology. So I'm going to end with saying this is an interesting time. This is the first time I've seen where we are talking, take care of the practitioners and take care of the patients. Normally we say, take care of the patients, take care of the patients, take care of the patients. We don't want any one of our colleagues getting depressed, anxious, and doing something that we don't want them to do. We're all in this together. This is not a problem of Saudi Arabia, America, India, anywhere. We're all in it together. We all need to learn from one another, and hopefully we'll come out of this stronger and better and help our patients in the long run. Thank you.
Thank you, Dr. Rahman. It's an excellent presentation, as usual. I appreciate your expertise in medicine and digital twins, and your talk about the anxiety and the impact on our healthcare. So by this, we are reaching our end of our speech by our speaker, and now we're going to open it to the queue and questions. And so we'll start with I have just. Man, do you have one of the most common question is the CME. So clarification,
Sure.
we have 2 CME hour by our so the Commission for Health Specialists. So it will be automatic through the registration link if you write your
so you don't need to receive anything, right? So you'll get the CME as soon as you're registered. So we will do the whole thing for you. You don't have to receive CME attendance. It will be directed to the Saudi Commission. The second component, there was a lot of compliments. Actually, mashallah, tabarakallah, we're at the moment, we're almost 2,000 attendee, 1.9K. Excellent presentation for all of you. Well done. There's a lot of questions. I went through at least 100 plus questions, but for the sake of time, and I know everybody tired, and we had a comment that, you know what, we should have been probably at 8 p.m. Anyways, it's just too many factors. I'll start. We thought probably we'll go through at least a couple of questions for each of the panelists, presenters. We'll start with Prof. Ahmed. Well received, excellent compliments, but I chose at least a couple, and yani, hopefully we can, if we have time, we can actually ask more questions. The first question came from Shayma Al-Madani. She was saying, what is the situation with patients with cancer, especially colorectal surgery? How long we postpone their surgery?
That's a good question, and at the same time is a tough question to answer. Let me answer about what happened in, at least in the city of Riyadh. Most of the hospitals, they give priority to cancer cases. So the cancer cases, they come first to be done. So if there is no other treatment other than surgery, then most of the surgery, they get done during this period of time. If there is any alternative like a chemotherapy or radiation, then basically after discussion in the tumor board, then we start with the radiation and chemotherapy, and then later on we do the case. From the literature on historically that once the colorectal case is being diagnosed, it should be done within 6 weeks. And any delay beyond the 6 weeks will affect the overall survival rate later on. So we try to do the cases within 6 weeks of the time from the diagnosis, if it is possible. And there are no other treatment options other than surgery.
I think there was a nice paper that I came across a while ago that detailed the different cancers and different risk factors based on weeks. I can't recall it right now, if I'm not mistaken, Prof.
That's
there was so depending on the cancer, multiple factors, they're actually giving the time-sensitive time with the new normal now. The second question came from Prof. Abdulazim Dawlatli. He was saying, is there any prognostic tools which will help to plan ahead during resuming process?
ليس المعلوم بأكل سائل.
It's a tough question. It's a good question, and I don't think that we have an answer to it.
And Dr. Abdul Azim, he should ask me, we work in the same OR. So privately, not in we like to have special instruments that is better than the other. I think but each hospital should develop their own scoring system. I think there in each hospital right now there is a disaster mitigation committee where they try to look at the day-to-day business in the hospital, and one of them is what's happening inside the OR. And I don't think that we should leave it to an individual. It should be a group of people from different specialties, whether in surgery or in anesthesia or from nursing point of view, and administration on top of that. And then they should look for a certain score system. They should form a task force where they go and review all the literature, look at what the other people are doing, and look at the local expertise as well as the local resources, and then after that they can come up with their own system. Right now, for example, in KKUH, we formed a committee between the Department of Surgery and Anesthesia and OR management, and they have to approve cases. And basically, unfortunately, since we are in this part of the world, the higher the voice, the higher the prioritization, unfortunately, in some cases. And whenever we put a system, we should give a leeway for surgeon to present cases that does not fit the score system. And at the same time, it has its own special condition, because we know that whatever we do as a scoring system, there will be an outliers where we have to accommodate these cases.
Thank you, Prof. Ahmed. Then a question, Prof. Rahman. As we all know that the anxiety and emotional infection is very, common now. What's your strategy like when this emotional infection and anxiety actually affecting the staffing and causing some psychological effect and affecting the operation? How do you, as a leadership, deal with such anxiety level?
So what we did was we were in the stage that you are now about a month ago. We divided up the surgical teams and the anesthesia teams into two teams so that there is no exposure between one and another. So one team was kept home so that they will stay home, relax, recuperate, and come. And the other team was in the hospital working. So sometimes what we saw was when it was used, the communication was open. If somebody felt stressed, they had to speak up. This is a new norm, and you have to give your folks time to say, listen, time to speak up. You don't look good. And when you ask the question, you don't give them a quick answer on how to solve it. You just listen. And does psychological stress impact patient outcome? Common sense would say yes, but we have not seen anything. Does stress increase medication errors? Yes, we know that. So we are using data from non-COVID times and applying it to COVID times. Stress and anxiety is bad. So open communication, open transparency, and I don't know what is the circumstances in Saudi Arabia. Is it okay to ask for mental help? Is it okay to say, I need to go see a psychologist? Is it okay to say, I'm going to go see a therapist? This is, even here, sometimes you'll get treatment easily if you have cancer or heart disease. It's very difficult to get treatment if you're depressed or anxious. But we have to make it more open and say it's okay to talk about mental health, because we don't want anybody committing suicide or killing somebody else.
Thank you, Prof. I have another question, I think for both Dr. Atasi and Dr. Rahman. So this is from Prof. Abdul Azim as well. So in the light of fact that pediatric patients are least affected by COVID, and John Hopkins, they do routine testing and screening, as well as I think National Guard. So the recommendation of screening versus testing, what do you, especially with the pediatric group? Abdul Halim, you want to go?
Sure. Well, honestly speaking, for us, we thought about it in different ways. So when you're doing the testing, it's not only the concern about the patient, it's the concern about patient and provider. And in order just to make sure that everybody on the same page and reassuring the providers, we decided to go ahead with the testing across the board. So every patient in the last, I think, at least in the last 4 weeks in Riyadh and 2 weeks and everywhere and across the corporate, we're testing every admission regardless of the reason for the admission. For the pediatrics, actually, we were willing, and actually we're thinking about going to the extra step because the kid doesn't come alone. He comes with his father or his mother, right? So the testing going to be for two, basically the patient and the one who's attending to the patient. And honestly speaking, that made us very comfortable in dealing with the cases. And when it actually paid us very well back, because most of the kids are asymptomatic and the disease is extremely mild in them, and luckily we didn't see the Kawasaki related disease. When the test, especially for those coming through emergency, as Prof. Mohammed Rahman said, we deal with them as suspected and we take all the precautions. And actually we are applying N95 and intubation for everyone. But when the test comes back as a positive and you dealt with the case in a very well-protected manner, that gave us a huge confidence into the system. And at least I can recall 3 cases in the pediatric OR that came back, the results came back positive, and we did the tracing, and every single individual has been exposed to this case was protected, and we did not have to isolate anybody. This thing makes the providers are much more keen to go forward and deal with it, and they feel that they're safe and comfortable, and probably drops the anxiety level significantly. Thank you.
Prof. Rahman.
I think in the olden days, I'm talking about olden days, is 3 months ago, we would say, what is the return on investment? Because anytime you go to your administrator and say, okay, I need to do this test for every kid, he'll say, what is the ROI? We can't do that now. So there's a group called the Pediatric Anesthesia Leadership Council that I'm a part of. We started talking about this about 2 months ago. And then we came up with a consensus statement, not evidence-based, but opinion-based statement that everybody's going to get tested. We have seen some cases where we didn't suspect. A simple example that is still we don't know what to do is COVID can present as appendicitis. So if a COVID positive kid who comes up with appendicitis, do you treat him conservatively or do you treat him with a laparoscopic surgery? So we have decided to treat it like a laparoscopic surgery and send him home the same day so that there's less exposure. So this is a new thing. So I think for now, testing is going to stay. The other question that comes up is if there is another surge, do we cancel pediatric patients if we have elective beds available? I think one of the things that we are telling the government is, if you look at the past history, this has not affected children. Children's hospitals have enough beds. If there's a surge, we continue doing pediatric surgeries with testing and the same precautions.
Thank you, Prof. Have another question for Prof. Mohammed Zbeidi. So the risk of post-operative complications is higher for those COVID patients. So the question is like, what are the etiology and the reason for that for post-op complication, especially for COVID patient and surgical patient? Mute. You're mute, Prof.
It's really hard to say, but I think it is the effect of the virus itself on the respiratory system, as well as the effect of surgery. So we know that the surgery by itself carries its own merit of morbidity and mortality. And when you add on top of that the virus, especially post-operatively, when they couldn't, when the patient protract or they get the infection, there is what I do believe it's a cytokine and chemokine storm inside the body that cause an exaggerated inflammatory response. And basically, if it is complicated by pulmonary complications, then this is really lethal to these patients. This is the main thing. The study that I showed, as well as Dr. Atassi showed, the mortality was high in all patients with a lot of comorbidities, an emergency procedure. So the patient himself already been cooked, and as a good material, it's a death recipe for this patient when he came in. And we haven't, I mean, they haven't noticed a lot of mortality in patients who are less than 60s. They haven't noticed mortality in patients who are less than 20, because the study has patients from the age of 20 all the way up to the age of 75. And the higher the high mortality was in the elderly patients. So I think it's mainly this patient comorbidities plus the viral infection caused the mortality on top of the complication that they had. Is it from the ventilator, from the ICU, or from the patient conditions? Hard to say. I think this is an area for a study.
Thank you, Prof. Just have another one point actually. As Saudi Anesthesia Society actually was going to conclude with the recommendation and the guideline we're going to be published, and whatever presented here actually it's going to be in this guideline. So we appreciate all your expertise and your feedback. Regarding the PPE, like I think Prof. Rahman mentioned that the using the PPE for all the intubation regardless of the test. So how's the nationally, like with the National Guard, Abdul Halim and Prof. Ahmed? Do you use the N95 for all the patients?
Okay. So honestly speaking, N95 becoming a very rare, a very expensive commodity at this current time, and that's from supply chain perspective. But that was a decision. We actually went down to calculate how many masks we're sending and we're releasing every single day. And we had a very, very strong grip on the distribution of the masks for the healthcare providers. But the quick answer is yes. So whenever we're dealing with an intubation for patients who actually booked for procedure, especially confirmed for sure, suspected for sure, if any, we go by the ARI. When we go by the test, if it's both of them negative, we take a regular precautions. If there's any question mark, actually, we will go the extra step and we do the N95 for all intubations.
Prof. Rahman, if we have a shortage in PPE, do you reuse the PPE or the N95? Or how do you?
We were using the N95 for a couple of days. So if you look at 3M's recommendation, it says that you can use it only for 3 to 6 hours. We were using it for a couple of days. And then we used the face shield and we were reusing that. But now we have enough. One thing we did was the anesthesiologist and the anesthesia team, like for example, if I am this attending, I have a provider, we tell, we are intubating now. So the entire team left the OR. And then we intubate and say, you're intubated, come on in. So that way we reduce the amount of N95 on the other folks. And then we did the same thing during extubation. We're extubating. So all other team members were leaving. We used to reuse the face mask, reuse the N95, PAPRs we used to reuse. But now I think we have enough supply, so we don't reuse.
Thank you, all the speaker. I know we are reaching, we are passing our time, and it was an honor and pleasure to have all of you with us. And the Saudi Anesthesia Society, we're gonna working on the guideline and the recommendation for a new norm of the new preoperative for non-urgent surgical cases. So it was an honor and pleasure, and we really appreciate your contribution and your time. Man, closing remark.
Yes, thank you very much for all the speakers, the attendee, for the chairman and president of the Saudi Society of Anesthesia, and all the board members. It was a very fruitful and excellent presentation by all three of them. Excellent interaction, excellent attendance. Please forgive us. There are so many questions, and a lot of them are good questions. But just for the sake of time and for the sake of sanity, we just thought we were just going to take it brief and take it easy on everybody. Stay safe, stay healthy, and hope as Prof. Rahman was saying, all of us are in it together, and hopefully this will get off soon. وربنا يكشف عن الأمة إن شاء الله جميعا. Thank you very much.
إن شاء الله. Thank you. Thank you.
Sorry.